Okay, so I think it's recording now. So we'll go ahead and get started. As you know, I normally do, I'm big on terminology, particularly here in evaluation, because people from a lot of different fields do evaluation. Okay? But with that being said, they don't all use the same terminology. Okay, so for example, in schools of public health, people talk about process impacts outcome. CDC goes the opposite, they go process outcome impacts. So, you really need to understand like what the terms are. And so when you get out in the field and you're talking to people, you can say, oh, this is what they mean by such and such. So, first things first, why are we even taking this class? Why are you guys even here? What's some reasons why we do evaluation?
To see how effective a program is.
Okay.
Determine the strengths and weaknesses and where it can be improved.
What else?
To see those implemented the way it was supposed to be implemented.
What else?
To see if it caused change, behavior change.
Okay. What else?
To show a reason to get funding in the future.
What else?
Were the objectives met?
That's my pen, guys. Oh. Okay.
To provide like community stakeholders with data on whether or not the program was applicable.
Oh gosh, this one's down too. Provide community stakeholders with what again?
With like data on the program's effects. Yes.
What else should that?
To notice trends also. You can see trends over time.
Review like whether or not the program is cost effective.
Any other? Tapped out? Okay. So, here's some reasons. To determine the degree of achievement of the program objectives, so you guys got that one, okay? You wrote all these objectives, said this is what we're going to do, and so now your evaluations to determine whether or not you met your objectives, you did what you were going to do. Document programs' strengths and weaknesses in planning decisions. So you got documenting or determining strengths and weaknesses. So what things did the program do well? What things could we improve on? What things didn't work so well? Always things that come up that sometimes you think of, sometimes you don't. You know, in terms of what could we do better. Establish quality assurance and control methods and to monitor performance. So you want to make sure that your program is being implemented with quality the same way every single time it's being implemented. Okay? And if you're talking about implementation with multiple people, you want to make sure everybody's doing the same thing. Okay? So if everybody's supposed to be teaching about low-fat eating, you want to make sure everybody's giving those same messages. Okay? You don't have one person who's sitting there eating McDonald's while they're talking about, yeah, you know, low-fat, whatever, it doesn't work, kind of thing. Because then that means your program's not going to be effective. So, and then you want to monitor performance. So as you're going along, too often we think about evaluation, or people think about evaluation as something that's done at the end of a program. And really you need to be monitoring all along, making sure your program's doing what it's supposed to be doing. Determine generalizability of the program to other populations and other settings. Okay, so we did something here, it worked, now we want to try it with another population or in another setting. Okay, even, you know, for example, we do an intervention in a faith-based organization and now we want to do it in a community-based organization. Will that translate? Will that work the same? Did everybody get that?
These notes are on mine.
They will be this summer, but not right now. Okay. So to identify hypotheses about human behavior for future evaluations. Okay, so remember, all along we've talked about the whole reason we're doing the work that we do is we're trying to change behavior. Okay, so in changing behavior, we hypothesize, we theorize based on behavioral theory, based on our program plans, our logic models. We lay out, this is what should happen. If we do these things, it'll make these changes, which will cause these changes in behavior, which in theory should cause these changes in health status. Okay? So doing evaluation allows us to hypothesize that and to test whether or not it's actually true. We also need to contribute to the science base for health education programs and really for public health in general. Okay, and sometimes we don't always do this very well. The academics do this for the most part, but our community people need to be talking about too. This is what worked, this is what didn't work. Been there, done that, we tried it, we're not doing it again, you know, those kinds of things. It doesn't always have to be published in a manuscript, okay? It could be presented at a conference. This is what we did, kind of thing. Even putting a report online. You know, nowadays Google is everybody's friend, or most people's friend. It should be everybody's friend. But, I mean, you know, just to be able for other people to read about here's what worked. The other thing that tells us most about what works is learning about what didn't work. So we need to be talking about things we did that failed, that didn't work, and why they failed, so that we can move forward. Improving staff skills that are going to be required for planning, implementation, and evaluation. So, you know, we want to make sure our staff is doing what needs to be done. The only way that we know that they're doing what needs to be done is if we evaluate, if we go in and we look at what's actually being done. If something's coming across, for example, you're implementing an intervention and people are supposed to be learning something and they aren't learning something, okay? Sure, first the knee-jerk natural reaction is, oh, well, you know, the participants were just stupid. But if it's something that you see across the board, it may not be that they're stupid. It may be something in the way that they're being taught, and then you have to go back and look at your staff and their skills. So you guys did talk about grant or contract requirements. Okay. Nowadays, you have to do evaluation. Even if it's just minimal documentation of here's how many came, here's how many participated, here's how many did, you know, whatever. That's minimal evaluation that always has to be done. Okay? And nowadays, too, with evidence-based interventions, the push from the feds is if you can document that people came, document that you did what you were supposed to do, then in theory, because it's an evidence-based intervention and you didn't make gross adaptations, huge adaptations, then you should get the same results. So you're not necessarily going to get funded to see if 6 months later there was change in behavior or anything like that. You're only going to get funded to see, did you implement the intervention as it was supposed to? Who did you implement it with? You know, those basic kinds of evaluation, because the theory is that if you implement that evidence-based intervention, then you'll have the changes that you're supposed to have. Yes?
So when does an intervention become officially evidence-based? After it's gone through like blind, like what do they have to go through to become evidence-based? Because I remember with my program, there was no evidence-based program for my target population. So I had to pick an evidence-based program and then modify it.
Mm-hmm.
So when does it become officially evidence-based?
So it becomes evidence-based after it's gone through what they call the rigorous evaluation. So sometimes that means the clinical trials. It means, what it means is you've done that implementation evaluation, that process level evaluation. You've looked at changes in knowledge, attitudes, beliefs, but you've also taken it out further and said, we also had changes in behavior as well. And not only have you gone through all of that, but you've done it with your experimental group and then a control or comparison group that doesn't get the intervention. And then it has to be published in the literature, okay? That's what sets it on the roll to be evidence-based. Then, of course, hopefully, particularly if it was federally funded, it may get picked up by, you know, the feds as, you know, identifying it, yes, this is an evidence-based intervention. Then it goes to, like, the people, I call the people the keepers of the intervention. So it might be, oh shoot, my mind just went blank. They're the people who have the interventions that you call and order the interventions from. So I think one is psychometrica, mathematica.
Cardia.
Huh?
Cardia.
Cardia is one. ETR Associates. They pick up the interventions and then they do what they call package them. So they'll come up with your intervention book based on what it is that you did, and they'll work with the developers of the intervention to come up with those materials, make them pretty, flashy, expensive. Right? I mean, those of you that have been involved with evidence-based interventions, buying these interventions can be expensive. And so, that's where they come in. They're the keepers of the intervention. They make, they mass produce the videos and things like that. The unfortunate part, particularly like with videos, is, like we do an intervention now. And we, shoot a video, we come up with something that looks really cool, that's really relevant now. It may not hit the market for 5 years. Okay? In which case then, clothes have changed, lingo's changed, all of that. So that's why, some of you that get these interventions or look at them and go, well, that video, why are they in a 1972 station wagon? You have to remember, it's a process to get to that point where it's evidence-based and it's out there. And then, once it gets out there and people start using it, then the keepers of the intervention, they will update the videos and things like that. Of course, all with the understanding of making money. Okay? Your ultimate goal, if this is the work you want to go into in terms of intervention development and evaluation and things like that, your ultimate goal is you want to get on one of those evidence-based intervention lists where the funder says, we will only fund projects that use these interventions. Okay? Because that's when your intervention is being picked up and it's being used. So, like HIV, I think I've referred you guys, or I've shown, like effectiveinterventions.org. CDC put that out. They, started with a compendium, and then it just kept coming from there. So now they have this beautiful website and blah, blah, blah. Office of Adolescent Health that did teen pregnancy prevention, they have another list of interventions. So that's your ultimate goal if that's what you're trying to get into. So, okay, but fulfilling your grant and contract requirements, again, they're going to want to know, did you meet your objectives? You said you were going to serve 100% of the population. Did you serve 100% of the population? It was mentioned about community stakeholders and providing them with data. So you do evaluation too for that positive public relations and community awareness. Okay, so you want people to buy into what it is that you're doing. You want people to see that what you've done has worked. So, if you made some kind of a change that people now have to go through, they want to see, hey, this is actually working. We're actually getting something from this. And people always like success stories, So as long as you can show those. Whoops, sorry. And then public and fiscal requirements. So again, related to that contractual piece, but also thinking about the money that you're spending, okay? Part of the evaluation is looking at that. Okay, so if you're looking at cost effectiveness or cost benefit, now you're looking at those fiscal requirements. If, you have to document for your funder how you spent your money, where did you spend it? And, you may even have to justify it. If you asked for $500,000 and you only spent $250,000, then you've got to explain why you didn't spend that money. Okay? Or if you asked for $250,000 and you tried to spend $251,000, then you're now going over, you have to explain that. What happened? Why did you do that? And part of your evaluation is documenting that. Here's what we spent our money on. Here's where the stuff went. Here's who we gave it to. Here's who attended the intervention. Here's why we went over. Maybe we didn't fully understand something or we had an unexpected cost, and this is why we went over. So these are the reasons why we evaluate. So these are the reasons why you're sitting in this class. And it's nowadays, with federal funding in particular, but also with other monies as well, everybody wants to know what is it that you did. Okay? On some level, what is it that you did? So that's why you're here in this class. So, all of these people here use evaluation results in some way, shape, or form. So, I mean, up to this point, we've kind of alluded to all of these. Are there any ones here that somebody's like, I don't understand why they would need evaluation results? Makes sense why all these people would want to know what happened. Did you do what you said you were going to do? Did you have any changes? What happened? Etc. Okay. So, again, next we'll flow into evaluation terminology. So kind of what are the terms that are out there? So a health promotion, health education, intervention program is something we've talked about. Again, reiterating what that is. So, again, same definition from program planning, not some random event, not something that you're kind of like, oh, I think we'll do this today, maybe we'll do something else tomorrow. It has to be planned, it has to be systematic, has to be replicable. So, for example, the goal is, okay, well, power doesn't seem to be working. The goal is to have other people use it. So if we're all gonna go out and implement an intervention, have to make sure everybody's doing the same thing. So that's what we mean by replicable. We're not just doing it just for the grins and giggles, but we want to get changes cognitively, so how people are thinking, affectively, so how they feel, what they value, what they believe, skill, okay? So we want to make sure people know how to do things, behaviors in terms of we want to make sure people are doing certain things, or health status. So we want to ultimately, that's why we're in public health, we want to improve health status. For a defined population at risk at specific sites, so at specific locations where we're doing the implementation for a defined period of time. So if it's an 8-week intervention, if it's a 2-hour intervention, whatever it is, we want to make sure that we're doing that. So that's what our our intervention or our program looks like. So my question always is a health fair a health promotion program or intervention? Thoughts?
I feel like it's not specific to a certain cognitive or skill or behavior change, unless maybe it's a targeted health fair, like that's a diabetes health fair or something. But even then, I don't think you're going to be able to evaluate if anything comes out of it. If they get anything, if anything, I feel it's a resource more than an implementable standardized intervention.
That's replicable.
Yes.
So we could, it's like, anybody think a health fair is an intervention? Everybody's like, she asked it like that, so maybe it's not.
Well, sometimes. I think it depends on the health fair.
Yeah.
Okay, so describe a health fair that you think would be an intervention.
I think it's like, if it's a targeted health fair at a targeted population and it's consistent, like going every month, there's a health fair there, then, it seems like you could have an evaluation process, like how many people went, whether or not they got whatever your health fair is targeted at. It seems like it could be moving.
Like if it's like an employee wellness health fair that they do every single year. And also, yes, it depends on the vendors you have as well. Because if you bring in say you bring in the community partners and you want to target certain behaviors like going to the doctor or smoking cessation or exercise, I don't know if that makes sense.
No, it does.
Okay.
It does. Okay. So let me ask you this. How many of you all have actually been to a health fair? Okay. Did everybody go to the same booth? So everybody didn't get the same information. And some people didn't get any information. They just went to the booth and got the candy, right? Okay. So, you guys are talking about standardization in terms of what the health fair it should be, in terms of the setup and everything like that, but not in terms of standardization in terms of what everybody receives. Okay? If somebody walks through and just picks up the candy and whatever other giveaways they have, that's not doing anything to produce any kind of changes that we want. Okay? So that's why a health fair is not an intervention. People love to do health fairs. And they love to say, oh, well, we did, blah, 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 blah. We had X number of testing for glucose, to see whether or not people were diabetic. Okay, but not everybody got their glucose tested. And just because they got it tested doesn't mean they got their results and doesn't mean that they're going to make any changes as a result. So it's not, it's kind of a feel good, it's easy, it's a low hanging fruit, but it's not, if you're going to be effective in changing behavior, running around the city doing health fairs isn't going to get it. Okay? And I challenge you next time you go to a health fair, and I know I shouldn't say this, but it's the truth. Okay? Go look in the trash cans in the parking lot. Or just outside the door. And see how many brochures made it to the trash can. Okay? I mean, that in and of itself ought to tell you. I mean, if people walked around the health fair, picked up a brochure, my car is right out here, and I threw it right outside, then that's not, I didn't have time to read it, absorb it, and go, oh yes, now I'm going to exercise 5 days a week, 30 minutes at a time, and all this criteria. Okay? The sad part is I know that based on my educational background. That's what I should be doing. Still not doing it. Yeah. So if I didn't know that and got a brochure in here and then walked outside and threw it in the trash, I didn't read it. I didn't like go, got it, okay. Like osmosis didn't just happen. I just didn't go, got it, you know. Or I didn't go, you know, okay, wait a minute, Jake's telling me what I need to eat now. He's a dietitian, got it, mind read, done. Okay? That's why a health fair is not an intervention or a program. Okay? Just saying. I know sometimes I feel like kids, not kids, but students go, oh, we want to do health fairs. I go, boom, and shoot them right down. Like I just shot that down, like, no, wrong place. So, here's a basic definition, comes from Patton. Patton is a huge name in evaluation, one of the, not originators, but one of the big names in the field. I knew that was coming. Yeah, slide it.
Does that work? Sarah, I'll let you.
Let's see. We'll do it. Turn it more. Oops. Like you don't want to look at me. Okay, so, the intervention, your evaluation's got to be systematic too. You can't just kind of randomly be out there collecting data. Looking at the activities, characteristics, and outcomes of the program. So you're going to be looking at what is it that you did. Okay? We like to assume that we did certain things, but we don't always know here's what we did. Characteristics, so like who participated, so on and so forth, outcomes, what happened. We did this, what happened. A program so we can make this judgment. So you got to decide about the program. Did it work? How can we improve the effectiveness of the program? Or make decisions about future programming. Okay? Who knows? Maybe we're successful. Everybody learned everything. We've wiped out whatever issue it was that we're talking about. So now, once we know we've done that, then we can move on to something else. If we weren't successful, maybe we need to change something. Maybe we need to do something a little bit differently to be more successful. Kind of what is it that we need to do in terms of our future programming? Okay, one of the most powerful things sometimes when you're sitting in meetings and you're talking about like future, like, okay, so next year we're going to do this and we're going to do that and we're going to do this, and people are arguing over why we should be doing or whether or not we should be doing. One of the most powerful things is say, hey, look, we did evaluation. We spent all this money on evaluation. We collected all this data. What did the data say? What did the data tell us? What do we need to do based on what was told, what was said? Do we need to change what we're doing? Do we need to continue down this path? What is it that we need to do? Not based on what I think, based on where I sit, based on where you sit, what do you think? But what did the data tell us? Okay? And that's why we do evaluation. So, fidelity. We talked about this in terms of planning. Fidelity becomes very important in terms of evaluation too. So, we talk about fidelity in terms of interventions. We talked about it in program planning, in terms of, you got to make sure that you follow the core elements. In terms of evaluation, we talk about evaluation. We talk about fidelity in terms of evaluation because if you don't follow the core elements, if you don't have fidelity, then we don't know what you implemented. It wasn't the intervention because you didn't have fidelity to the intervention. You kind of did your own thing. So now we've got a whole different intervention. So if it worked, we don't know why it worked. We don't know what you did that made the changes. If it didn't work, we know that it didn't work because you didn't do what you were supposed to do. Okay? So that's why, fidelity becomes very important, not just on the planning side in terms of thinking about getting people to implement because we need this intervention, but on the evaluation side, we can't, if we don't have fidelity to the program, then there's no sense of moving forward with the evaluation because you don't know what was done to cause the changes. Okay? If you have fidelity and you can document that, then you can say, okay, it was the program that caused the changes. So that's why fidelity becomes very important. So, some types of evaluation that you'll hear people talk about. One of them is qualitative evaluation. So, qualitative evaluation basically means you're using qualitative methods, okay? Whether you're doing interviews, in-depth, open-ended interviews, you're doing some kind of observation, you're reviewing reports, you may even do focus groups, but you're using that qualitative data to look at whether or not, why the program succeeded or failed, and looking at the perceived value of the program or of the intervention by the staff. So it's really more qualitative focus than anything. Most times, most people don't have experience doing qualitative data collection and data analysis or the resources to do that, so it's not something that's widely done in public health. Oftentimes you have to bring in a consultant to do that. If you're doing if you're in a community-based organization or a health department, or you partner with, academics who do that kind of thing. It's not something that's always widely done, but it is an option. It's something, to think about, particularly if you really want to understand, like, okay, we like talked to the community, we had their buy-in, we thought everybody was on board, and, it didn't quite work right. Like, what happened? Where did we go wrong? You might want to consider more of a qualitative kind of thing. But that's just one type of of evaluation that you'll see. Another type of evaluation that you'll see a lot is called formative evaluation. And formative evaluation is a little bit different than qualitative evaluation. So in formative evaluation, you're using qualitative and quantitative and or either one. It kind of just depends on what your expertise are. And you're really doing it early on in the intervention development, early on in the implementation, to really kind of see, like, how is this working? How is this working for you all? So you're looking at these particular things. So if you think about early on in program implementation, you decide, okay, this is what we're gonna do. If you don't make any changes, it's more likely a pilot test of the intervention. You're just going through a run through. Formative evaluation. So you're trying to see, is this feasible? Is it appropriate? What kind of changes can you see in the short term? So it's really, like a quick dry run of the intervention. Let's say you change something in the intervention. So not the core elements, but you change maybe, I think last semester Brenda's group took an intervention designed for African American women and changed it over to Hispanic and Latino women. Okay? So now they want to see, okay, we kept the core elements, but we changed a few things to make it more specific to that particular population. You still want to go back and do some of this formative evaluation just to make sure, is it feasible? Are things appropriate? Are you getting those immediate changes that you should be getting? Okay? You shouldn't just be jumping out there, although I know a lot of times a lot of us do, jump in there, like, oh, we got the intervention, okay, let's go, and jump right in and never look back at, was this even feasible? Okay? And sometimes that's a huge question. When I ran the Teen Pregnancy Prevention Project in African American churches, we went through the pilot test and, everything worked okay. But, we were experiencing some pushback from churches about doing HIV prevention, condom demonstrations in churches, things like that, which you have to kind of listen to because, you might have to change something. But we went back and we looked at the list of evidence-based interventions and, in terms of looking at the needs that the churches had, like, we knew it wasn't going to be something that was going to be a long intervention. We didn't want 16 weeks, 20, 24 weeks, those kinds of things, because that's just long to get people to commit to. I mean, we as a staff didn't want to commit to that, so why would we expect anybody else to commit to that? We wanted something that was going to be boys and girls. We wanted something that was going to involve condom demonstrations, not just talking about this is what you're supposed to do, but teaching them how to do that. And we circled back around to the intervention that we had. And, once we did that, it was like, okay, well then that's what we're going with, But we had to look at all of this and was this appropriate? Did it make sense? All of those things in terms of moving forward. So some of the questions that you answer in doing formative evaluation is looking at whether or not the intervention is designed or to be modified to meet the population's needs. Okay, so if there's a particular point that people aren't getting, then you might need to look at changing something. We looked at what can we learn from the pre-testing of our approach. So were there things we could have done differently? Were there things we could have done better? Okay, and then are the materials that we're going to use appropriate? Do people understand them? Okay, and in the big scheme of things, some of these might seem like minor details, but they can be very important. And so almost, unless you've been doing an intervention for a long time, already and now you've got new money and you're just, continuing to do the same intervention, you really need to think about pilot testing your intervention, making sure it's okay, watching, like, you might have somebody who's implementing the intervention and they're teaching the class and da 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 da, but then you have maybe another staff person who's in there just watching, like, how are people receiving the intervention? Are they sitting there going, what? Like, I don't understand, Or there are a lot of questions that they're like they don't understand a particular point you're trying to make, or the materials don't seem relevant. We've even had to coach people through, the video comes on and it's got the 70s, station wagon, and, particularly if you're dealing with young people, okay? Which, if you're talking about a 70s station wagon, you're talking really about anybody under the age of 25 or 30. They're going to get caught up in that and miss the message of the video. So, we've coached people like, look, before you turn on the video, let them know that this is a little dated, and don't get caught up in that. Watch, think about the message and listen to what's being explained, kind of thing. I mean, all of these things that make your intervention implementation better, and make sure that you address your population's needs. Make sense? Okay. Yes.
So let's say you do a pilot study and you come out going, for example, you're doing like Latinos or something,
Mm-hmm.
and you find that you actually need to have Spanish speaking video or something for, you change the material substantially. Do you then have to do another pilot test to make sure that that's working before you then do the full implementation?
In theory, you should.
Okay.
Okay. The reality is most of us are under a clock, particularly if we've been funded. So, I mean, as much of this ahead of time in terms of like the planning piece of it, like think about the program planning and the administrative and policy assessment. You're supposed to think about some of these barriers. Okay? So if you've got a primarily Spanish speaking crowd, you gotta think about, okay, maybe I need to have some materials translated. If that's not feasible, then you really need to rethink what it is that you're doing. Okay? If you go ahead with the intervention and you're seeing something's not right here, then you gotta think through, okay, what is it that we can do? Because ultimately what you want your intervention, when you're dealing with funders, what you want your intervention to show is that it worked and that you did what you were supposed to do. So if you've got an issue, you can't wait till the end and go, oh, darn, oops, we weren't successful, You need to catch that early on and say, make some changes and stuff. And, some of this becomes, again, assuming you're not working in a vacuum by yourself. You're working with other people, so you're getting this input and this feedback. Again, you need to listen. There's a reason why you're doing the evaluation. Listen to what the evaluation is telling you. So, okay. Now, your question. Evaluation research. So if you want to look at a new intervention, then really what you're doing in terms of evaluation is now evaluation research. So, evaluation and research comes in to Amanda's question early on about what makes an intervention evidence-based. Okay? Evaluation research is what ultimately has to happen. So, you either, the new intervention is a key piece. You either develop a new intervention or you've changed the core elements of an intervention, so now it's a new intervention. So now you've got to do either some kind of, remember your research designs, some experimental, quasi-experimental, so that you can look at feasibility, efficacy, cost effectiveness, or cost benefits of that new intervention. Okay? So now you're trying to show that it is evidence-based. Okay? So that's where the evaluation research comes in. Now, for most of you in the room, at a master's level, you're going to be going into health departments, community-based organizations. You're not going to be doing this level of research. Okay? For the doctoral students, there is that potential. You could be doing the evaluation research. Let me just say too, at a master's level, if you go into a research setting, you might be the program coordinator for something like this. So you're overseeing that research, but somebody else is thinking, somebody above you in terms of an academic is thinking about, this is the evaluation we need to do. They're just, now directing you into and making sure you run the evaluation as it should be. So, most times, again, health departments, community-based organizations don't do this kind of work. If they are involved in this kind of work, it's because they've partnered with usually academia or some other kind of research institute or whatever, and are working with them, and so they're a site for that evaluation. So either they're implementing the new intervention, or they're the control site or the comparison site, those kinds of things. So, but again, some of you may reach this level, so you may be involved in that. So that's why I give you this terminology. Program evaluation, which most of you will be involved in, is looking at a tested intervention in terms of long-term changes. Yes.
So, would this be an example, so you give like an 8-week intervention and you come back a year later and give them a survey to find out if they are still enacting the behavior change skills that they learned in that 8-week program?
Mm-hmm. Except you probably wouldn't like leave them and come back a year later. You'd probably come back, various points through that, so you could see like at what point did the behavior change fall off.
Okay.
I mean, think about, things becoming a habit. How long how many times it takes for somebody to do it before it becomes a habit. So depending upon the behavior, it might not be something that you have to wait a year to see. Like, you should be able to see it, like in some cases, 3 to 6 months out. Some cases it might be 30 days out, you see the behavior change. Okay? The key thing though is that this is a tested intervention, and you're looking at long term. And long term is not like forever, Long term, again, think about the behavior and how frequently the behavior occurs. If it's something that happens pretty regularly, then 3 to 6 months could be considered long term. So it just kind of depends on where you are. So the other thing too is I also have this also known as summative evaluation, because you'll hear people talk about formative evaluation and then summative evaluation. So formative is in that early development stages. Summative is now at the end, kind of what did you find kind of thing. So again, when you're talking with people, some people will talk in terms of formative and summative, and so you're not going, what are they talking about? At least now, you can say, you can go, okay, let me go home and look that up. Then you can go back to your notebook and go, oh, here it is. We talked about that early on. This is what, in my world, this is what it means. Cost effectiveness analysis, cost benefit analysis. Not always something that we in public health do. So as an evaluator, it's not something necessarily that I do, but I often provide data, information that other people use to then figure it out. So if I'm implementing a program, then I provide the information on the costs and what it is that we're doing, and then somebody else calculates that. So cost effectiveness looks at the relationship between the intervention costs and then the impact rate. Okay, so how much change you're seeing, how much does it cost relative to how much change you're seeing. Okay, so it becomes a ratio of cost per unit per percent impact, or of percent impact. So when people say for every dollar we put in, here's how much, the impact is in terms of behavior change or whatever, this is what they're talking about. It's cost effectiveness analysis. People specialize in doing these, and so, you would probably, it's beyond the scope of this class. Like I said, it's beyond the scope of the work that I do. So if I were, to be involved in this, I would be working with somebody else who would be calculating this out for me. Cost benefit analysis So again, looking at the relationship between intervention costs, but here now we're looking at a health outcome rate. So, here, again, it's that for every dollar that we invest in teen pregnancy prevention, HIV prevention, here's the number of cases we prevent, kind of thing, is what you're calculating here. Again, something that is one person I've been around who does this was like an economist. So he calculated this out. We had to provide our costs, for doing something. So sometimes so when you think about the cost of the actual program, sometimes they don't want the cost of like the management of the program or the travel back and forth, but the actual implementation of the program they want the cost of. And then from there they can calculate the rest of it. Again, if you were involved in something like this, you're going to be working with somebody who does the calculations, and most likely you're going to be involved in saying, okay, here's, like for me, I've always said, here's our sponsored programs, sponsored programs, I give them permission to have this information on our costs, okay? And I've been involved in that a couple of times where we've had to say, those things, and people then are calculating, here's how much it actually costs to do something, and then here's how much, based on how much was put in, here's how many lives were saved, or how many cases were prevented, or things like that. So it's looking at a monetary benefit consequence kind of relationship. So, and again, I present these terms not because cost effectiveness analysis and cost benefit analysis, not in terms of it's something you're going to learn in this class, but more in terms of, some of you all are going to be out in situations where your funder is going to ask for this information because they're doing a cost benefit analysis or cost effectiveness analysis of the overall program, not just necessarily your program. The other part of it too is you might be reading articles, about, okay, so, what's our return on our investment? What kind of cost effectiveness, cost benefits can we expect to receive if we do this intervention? Like, how much is it going to cost? What are we going to see in return? And so, at least now you can refer back to this and say, okay, I've heard of these terms, and here's where we are, kind of thing. So, last two terms I want to talk about are efficacy and effectiveness, because people use those terms interchangeably, and they're really not. So, efficacy is the first term. And efficacy is really about a new or an untested intervention. So, efficacy, you're looking at the degree to which the new or the untested intervention produced significant changes in behavior or health outcome. Okay, so the question becomes, did the intervention produce significant changes among the sample of the population at risk under optimal program practice conditions? Okay, so optimal being the operative word here in terms of under the ideal circumstances. You got plenty of copies, everybody's on time, everybody knows what they're supposed to be doing, like everything is just right. Like you need new pencils and your boss is like, got it, done, you know. Go to the store, run, grab the pencils, got it. You need copies, got it. Okay, optimal conditions, you know. In other words, like you've seen the commercial where, and I forget what the product is, where it was for some baby product, and it's like the first child, and you know, like everything is like pristine and clean, and you know, everything is just perfect. The second child comes along, and she's slinging stuff around, and it doesn't matter. Okay, the first child is under optimal conditions, where we're looking at efficacy, okay? Everything's gotta be just right, you know, so on and so forth. Effectiveness then is now we have a tested intervention, so now we have a second child, or third, however many. And so now we're documenting internal validity in terms of producing changes that we want to see. Okay, so again, tested intervention, when we say documented internal validity, we mean that it has been shown that when it's the intervention's implemented as it should be, it causes the changes. Okay, so in this case now we're just looking at did the existing intervention, the tested intervention, cause the changes that we wanted to see. So the question becomes, did the intervention produce significant change among a large representative sample of a well-defined population at risk under normal program practice circumstances. So again, going back to the children example, you know, the first child, they drop food on the floor. You're like, oh my God, I gotta get a disinfecting wipe and I gotta wipe it up. Okay, optimal conditions. Second child drops food on the floor. You're like, the dog will get it. Call the dog licks it up, and boom, you're, it's like normal conditions. Okay, these are the things. Those of you that have kids know, or you've been around younger siblings know. These are the things that happen. Like you don't get. Under normal conditions, some of the stuff you don't get caught up in. So, in terms of terminology, any questions, any comments? I know it's kind of boring and it's kind of like, but it's very important because so many people claim to do evaluation, and everybody's using different terminology. Okay, so now I want to talk about kind of domains of planning, evaluation, kind of what goes into that, and kind of how do we balance all of that. Okay, so you've got policy, you've got practice, and you've got science that are going to influence your planning and your evaluation. So, we'll start with the science first. And so the science base is the evidence base for interventions comes from these meta-analyses or these meta-evaluations. So these big review articles that you see where they look across all these other articles that others have done and kind of seen like what kind of change you can expect, what kinds of things work best, what kind of things don't work best. So in terms of evaluation, the science is going to tell you like what rate of behavior change, for example, you can expect to see. Okay, so for example, we know, I'm trying to think off the top of my head, from smoking cessation programs, they are, first of all, they're not 100% effective. Okay, number one. I want to say their effectiveness is around 12 to 15%, but I might be a little off on that. But we know this based on somebody's gone through and looked at all of the smoking cessation programs that others have done and said, oh, well, they got this amount of change, they got this amount of change, they got this amount of change. And then based on that, they've said, here's on average what you can expect. Okay? So let me tell you something. If you're going to do a smoking cessation program and you're going to say 100% people are going to stop smoking, that's not realistic. Okay? And that's where the science comes in. You've really got to look at the science. Even now with the evidence-based interventions, they tell you, here's, what we found in terms of our results. Here's how many people, made this behavior change. And, in a lot of cases, they'll tell you immediately post and at some point, follow-up point after. Okay? So, for you to expect something well above and beyond that is kind of, you're setting yourself up for failure. It's kind of foolish. Okay? So that's, again, where the science comes in and telling you all of this. So, you gotta look at, excuse me, all the evidence that's out there. And not just be in a vacuum and thinking about what it is that you're gonna be doing. This is, again, why the evidence-based interventions become so important, is looking at what's already out there. For the doctoral students, I was at the National HIV Prevention Conference, I guess it was 2 years ago? 3 years ago, 2 years ago, 3 years ago, or 2.5 years ago, just over 2 years ago. And one of the things that they talked about in terms of the research is, look, we already know how to prevent HIV. You use a condom if you're having sex, or you don't have sex. If you're infected, you're on your antiviral medication, antiretroviral medication. And if you're in a high-risk situation, so, you may be in a discordant situation where your partner is HIV positive and you're not, now you're on PrEP, okay? They're like, we know those things, if we can get people to do those things right there, we will prevent the spread of HIV. So now proposing all this other research for something else, or we're gonna try to understand no, we already know. So understand what the evidence is saying. Also understand too that this is why interventions show up on a list at one point and then a few years later fall off the intervention list, because they've said, oh, well, you know what, we did the behaviors in terms of abstinence and condom use, for example, if we're talking about HIV. But now PrEP has come along. So now the interventions have to incorporate PrEP. So it's, it's an evolving everything is evolving as we learn more and things like that. So understand what the science is saying. Understand what it is that the interventions need to be talking about. Understand too that that's, like you might have been doing an intervention 3-4 years ago that's no longer considered evidence-based. It's not because the intervention was bad, it's because our knowledge base has changed. Okay? And so that's why you always got to be on top of the knowledge. So the science is going to, kind of document that theoretical behavior change model for the intervention as well as its evaluation. Okay? So the science is going to tell you these are the things that you need to be looking at. Okay, so like, you guys were asking me about the conference I was just at. One of the things that they were saying about PrEP, for example, which is that anaphylaxis drugs that people can take in order to prevent getting HIV, is ideally, yes, people are on it on a consistent basis. However, in the event that they, maybe can't afford the medication, so you get a 30-day supply. Hey, you're going to Vegas for the weekend, and you're going to be out there. Like if you start taking the medication like 48 hours before you get here, and the whole time that you're here, and maybe 24 to 48 hours afterwards, you still can prevent and minimize your risk of getting HIV. Okay? So you gotta understand the science of what's going on and stay updated on the science. So the science is going to influence what you do, but also policy is going to influence what you do. So obviously, the philosophical, political, financial, organizational base of support is huge in influencing what goes on. Okay? You gotta look at who really supports or opposes the intervention and its evaluation. Okay, so, the availability of marijuana. Huge topic right now. Okay, state of California just allowed recreational marijuana. They've had medical marijuana, they've never had recreational marijuana. Same here in Nevada, just in Hawaii. Interestingly, you can get medical marijuana cards in Hawaii, but there's limited dispensaries. Okay, almost no dispensaries where you can get it for. So it's it's kind of interesting. Everybody's saying, oh, medical marijuana, it works, it does this, it does that. Understand, very limited research occurs in this country on medical marijuana. We don't have a full understanding of the breadth and type of marijuana that people are using it, what are they using it for, and how are they using it, and so on and so forth. And part of that is political. Okay, it's very much political. And so you got to understand that. And even, our representative here, one of our congressional representatives here in Nevada, Dina Titus, is, a big push to roll back some of the federal restraints on marijuana and things like that. The White House and the administration and and now the Justice Department are pushing to make those things even stronger. I guess Obama had rolled back some things. They're trying to, put those back in, despite now all of these states now having recreational marijuana. For me, the science isn't there to say whether or not it works or it doesn't work, but the politics is definitely there. When you talk about, is it politically sensitive? Heck yeah, it is. Especially when you're looking at who's now benefiting and who is in jail over marijuana. It's very much politically motivated. So even then, when you look at, based on who owns dispensaries and things like that versus who is in jail and has been in jail for a long time over marijuana, then when we start talking about what types of questions should be answered about marijuana, it's those people sitting in jail right now over marijuana use, possession, distribution, and things like that aren't being involved in asking what kind of questions we should be doing for the evaluation, or whether or not there should be an evaluation done. They're being completely left out of the picture. And it's now all of these people who've got a lot of money, a lot of power, who are coming in. And now if we ever reach a point where we're really doing some research related to marijuana or evaluation related to marijuana, they will be the ones who will be determining all of this, despite their knowledge or lack thereof of marijuana. It's an interesting process, and the politics are huge in all of this. And I think sometimes we in public health don't realize how strong political forces are in things.
Until NIH gets cut by $80 billion or whatever,
right? Right. I mean, so for example, I was involved in the drafting of the perinatal HIV transmission bill in this state. And I remember one of the state senators saying to us that, they wanted to be careful in wording the bill in such a way that it did not project what's really unique to Las Vegas, because most of the cases where children were becoming infected, babies were becoming infected, were here in Las Vegas. Didn't want that being projected to the rest of the state. So if we're requiring HIV testing here, we don't want to, for the state, we don't want to make that seem like a statewide issue when it's really almost a Las Vegas issue. So it's just very interesting how people think about the bills and the legislation, and even you've been watching what's on some level, and I haven't been in detail on what's going on in Congress right now and how things are negotiated so that things happen. And you got to understand that, because that has influence on the work that we do, whether it's influence in terms of the research that's being done or influence in terms of the programs that are being implemented. Okay, I talk to my former staff sometimes about, we didn't get funded for the next round of teen pregnancy prevention money. Were we devastated? Of course. Upset, people were losing jobs and things like that. However, in the second year of funding, a lot of programs got cut because of the politics. And so, we were kind of like, yeah, while we're sad we didn't get funded, we're glad we didn't get funded and then get cut. Because that would have been that's even more devastating, is when that happens. So you got to think about the politics and how am I going to use these evaluation results? You don't want to make a group look bad if something didn't go right, but you need to tell the truth. But all of these things are factoring in.
I met someone who was doing an HIV prevention program, and they got their 5-year funding cut after 2 years, and it hurt their evaluation because they had planned how to evaluate it and just write in the papers and all the stuff that's supposed to come out of it. And so there they are wrapping it up after year 2, and then they're all looking for new jobs, right? And it's so frustrating to think that they came in with this guaranteed money that was then literally just poof, gone.
Right. I mean, the feds will tell you, yes, you're funded for 5 years, but it's a year-to-year funding, and my gosh, they mean that. Having been around cuts before, they mean that. So, understand the political side of it, because yeah, like you said, it could result in your program just completely going away.
I think I would also like to add how it's also like it's political, but it's also very much philosophical too. Like these ideas of what they think is right, and that's why they implement these policies. Like right now, our funding is getting cut, but abstinence money is like coming back, right? Like we're starting to the announcements for abstinence-based programs are coming out, and so I feel like that's a philosophical.
Right, which contradicts the science.
It does.
Like the people who want to bring the DARE program back. It's like, the DARE program didn't work. Abstinence doesn't work. Can we just stop the madness and listen to the science? But, that political side is in there too. And so you have to understand that. The other side is then the practice side in terms of what's the state of the art. So, I'm like sitting here thinking, I've been around in the HIV world long enough to see, the evolution of these evidence-based interventions. So initially there were no evidence-based interventions. Everybody just kind of made up their own interventions, did their own evaluations and things like that, which wasn't really cost effective. You're giving, especially like community-based organizations, you're giving them money to do this evaluation that they may not know or understand. And so during my work in capacity building with CDC, that's initially what we were pushing people to do is, come up with, what do you think works? Okay, design a program, blah, 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 blah. And then there was a switch, hey, it's about evidence-based programs and EBIs and evidence-based interventions and what makes an EBI and no, you can't make it up and blah, 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 And there were a lot of interventions that were out there and things like that, and there still are. But now we're seeing another switch to, PrEP use and, getting people, to be, right now my mind is going blank, undetectable, kind of thing. Like if we can get people to be undetectable, then, they can kind of do more of whatever kind of thing. And so it's, it's kind of like, what's the state of the art? So even now, there's some discussion and thought around, community-based organizations, because they are in the community and they reach people and they're, with the people, that maybe they need to have partnerships with clinics in order to be able to offer PrEP. So, marrying those together. So you got to really know kind of what's the state of the art. Part of what knowing the state of the art is you can't sit in your office and just read articles. And you can't just be in your state listening to people in your state. You've got to go to these national meetings and these national conferences, or talk to people who are going to these national meetings and find out what's the state of the art, what's going on, what are people talking about, okay? Because that's important and that drives the work too. And so then if you're talking about state of the art, you've got to then be looking at infrastructure and capacity for that new intervention. Or is this going to just be significant revisions to something that you're already doing? And so a lot of times it's not just hearing about, oh yes, everybody should be on PrEP kind of thing, but it's hearing how people are implementing it, what are they doing, how does it, I'm thinking through then, how does this translate to where I am and what we're doing, and how, do we have the capacity? Is this something we need to change? Do we need to rethink, our partnerships? If the push is going towards PrEP, do we need to rethink that and say, okay, hey, maybe we need to now partner with a clinic in addition to the health district and so on and so forth, because we need somebody who can prescribe medication. So it's, it's those kinds of thoughts. It's not just, we're now going to show a video-based intervention, or we're going to do an app as opposed to classes. It's, some of this is becoming a little bit more complex. So obviously your practice, the practice is influenced by your staff. Okay, so you got to look at, what are they capable of? What are they willing to do or not willing to do? And whether or not you can make changes in that. And then looking at salient characteristics of the population at risk and the setting that need to be considered. Are there things that, based on your experience, you need to consider? So, at one point people were like, oh, well, if you invite them, if you have the program, people will come. They'll just come, like a field of dreams. Oh, if we build it, they will come. Everybody will come, okay? And then after a while, you start realizing, yeah, some people will come, but most people won't come. And the people that you really need to come definitely aren't coming, okay? Usually the ones that come are either the ones that are really super interested or the ones that are bored and they have something to say and they can have an axe to grind, okay? So then the thought process became going to these, ready-made groups, these captive audiences. So, you want to work with youth. Okay, well, now instead of saying, hey, youth, we're going to have something over at UNLV, you now go to the youth, I mean, it sounds pretty, well, duh. But for a while it wasn't happening, and now it's like this big push, go to the youth, go to the after school programs if you want to work with the kids and, things like that. So you've got to kind of learn from your experience, okay? People talk about Las Vegas all the time. And when we talk about implementing programs in Las Vegas, it's like, okay, well, first of all, it's hot in the summertime. People ain't trying to go nowhere. So if you're talking about a population that travels by bus, summertime ain't the time to do something. Okay, you gotta, say, okay, this is the experience, this is the practice side of it. All of this sounds great, but how do we, in reality, based on our experience with what we've done, how are we going to implement this? Okay, so, kind of in thinking about all of this, you got the science that says you're supposed to do one thing. You got the politics that say, yeah, but we don't want you doing all of that. And you got the practice that says, but this is what the state of the art is right now. Or this is based on our experience, this is how best to implement it in these particular situations. So, you've got to kind of, not only in your planning of your program, but also then in your evaluation. Okay? Prime example, we said, oh, we're going to do online surveys. Everybody has access to a computer. Okay? But again, that's us as academics talking because we got computers in our offices, we got laptops, we got computers at home, we got all this stuff. Okay? Not thinking about average person may not have a computer, or if they have a computer, they don't have internet access. And the only internet access they have is on a phone. Okay? Most everybody now has a smartphone, but depending upon the population you're trying to reach. Some of them still got flip phones, and they're quite damn proud of their flip phones because they can slam it shut when they hang up on somebody. That was the best part of doing a flip phone. That's like it's kind of anticlimactic to go, hang up, like that. Slamming that phone shut was like the best part of a flip phone. And so then like now we're like, oh, people don't have, computers with internet access. We've now got to have surveys that people can fill out on their phone. And, we got to make sure it's accessible via their phones. And we don't always think about that. And now if you've got an elderly population who has a flip phone, that online survey ain't gonna work. Okay? And like my mother, she'll die if she knows I'm telling you guys this, but she uses her pinky to do whatever on her phone. And, everything of course has to be big so she can see it real easily and things like that. But it also makes it hard. Like now if you can't see like a page on your phone, you're like, what? I gotta do, who wants to do that? So you can imagine now, we're all good with our thumbs and we can da-da-da-da-da-da-da. But now if you're doing one finger, who wants to type something in? Like the days I'm like, okay, Mom, I'm driving. I'm like, send so-and-so a text message. we're damn near there, and she's finally, okay, I just sent the message. I'm like, you know, we have to balance, we have to understand and balance all of this when we're working with people, when we're collecting data. You know, Lord Jesus, she had to fill out a survey on her phone. I don't think she wouldn't do it, and especially not something where she had to write, you know, a response in. And those are the things that we need to think about, like just dealing with IRB. And I have an undergraduate student, and she was going to do an online survey, but she was going to have paper surveys as well. So Joanna, this is what we decided. Well, IRB said, no, state of the art is online surveys. So she cannot do paper surveys. Which, I mean, part of me wanted to question, who are you, IRB, to be making that decision? But, I mean, you know, it's kind of, this is where we're going towards. Yes, ma'am.
Like, so for my research, I'm considering doing this with an older population, so it's like, would you be able to justify to the IRB why you need the paper surveys or why you need that? Because
Yeah,
of the
you need to say more than just it's an elderly population. You might need
visually impaired.
Yes, visually
Yeah.
and be specific about, you know, about this is how many are visually impaired or are
In
not
the
tech
state of Nevada, the
savvy,
disability rate,
right,
blah, blah, blah.
or have, you know, dexterity issues, things like that. Because otherwise they might say, no, you need to do an online survey. So, yeah, because we have like inclusion criteria of, you know, we're dealing with the immigrant population, must speak English in order to complete the survey, or must be able to complete the survey in English. They said no. I said, well, they said, well, why aren't you translating it? I said, because one, it costs money, and I don't have money. Two, it takes time, and I don't have time. This is an undergraduate student I'm trying to get graduated in May. It doesn't, you know, we just don't have that kind of time. They were like, well, yes, while those are valid reasons, we need to know, like, what percentage of that population does not speak English or speaks English or, you know. And now I'm like, I'm on Google, you know, but she's doing Ethiopian immigrants. You can find information on African immigrants and how many, but, you know, that's like saying, in South America, how many speak English? Immigrants from South America, how many speak English? Or from Europe, how many speak English, but not going to each individual country? So that criteria came out as well. I mean, I'm like, okay, you know, let's all right, let's play the game. This is what you want, this is what we're gonna do. So balancing all of that, you know, becomes a challenge and a trick in all of this. Okay, so in this last 30 minutes, and I know you guys are going to be blown away because when you actually see the document, the CDC framework for evaluation, it's like 200 pages. So we're about to do this in 30 minutes. So, the framework. MMWR, you guys should be familiar with that. Morbidity and mortality weekly report. So in 1999, CDC came out with this framework. Guides all of the evaluations that are done through CDC. So they have steps, and then they have standards, okay? And so we'll go through the steps and then talk about the standards. So the steps, almost like program planning. So you engage the stakeholders, okay? So the people who have a vested interest in the program, you engage them. Then you describe the program, okay? Again, where your program plan comes into play in describing the program, and here's what the program was designed to do, your objectives, blah, blah, blah. Then you're going to focus the evaluation design. So you're going to decide what is it that you're going to evaluate. Okay? For your evaluation plans, I'm basically going to make you evaluate everything. Okay? So that you have that experience. In the real world, you may only be looking at a particular level or a couple of particular levels or a couple of things related to the program. Okay? So once you decide on what you're going to evaluate, you focus the design, then you're going to gather credible evidence. Okay? So this is where you collect your data. Okay? It may be quantitative data, it may be qualitative data, it may be a mixed methods, but you're going to get good data. You're going to analyze that data and you're going to come up with some conclusions, okay? So you're going to justify your conclusions based on this data. Okay? Then you're going to ensure use of the evaluation results and share your lessons learned. Okay? In other words, what you don't want to have happen here is I have a FedEx envelope at my house that, let's see, this is 2018. It's probably been at my house 10 years or more that has the evaluation report in there. Okay? I never opened it. Obviously, didn't really read it. Heard enough about it to be able to talk about it in meetings and things like that, but never, that's the evaluation report you don't want. You don't want it to send it to somebody and it sits on a shelf and nobody uses it. Okay? You want to be able to share that back in and go around the circle again. So once you do your evaluation, then you're going to once you share your results, you're going to engage the stakeholders again, and you're going to decide, okay, do we need to do this program again? What do we need to change? Continue down the same path, etc. And so then you come back and do the same thing again. Okay? And then we have the standards here, which are kind of like the overarching principles of the evaluation. Okay? So these are going to be the things that are going to guide what it is that you do in these steps. So in terms of the standards, one is utility. So you need to make sure that the evaluation meets the need of the intended users. Okay, so if that's you and your staff, then what is it that you need to know? And is that going to be useful? And how do you collect that data so that you get useful data from it? Okay? Some of this comes kind of easy, like you might know some of this. Some of this comes with experience. Okay? So you think you are collecting it one way that you need it, and you realize that's not really telling you what you needed to know, and so now you need to go back and relook at how you're collecting the data or what it is that you're collecting. So just know that, you may not always get it right, but it'll take some time. Okay? Feasibility is important. Is the evaluation realistic, prudent, and efficient? So thinking about, in particular, your data collection, is that feasible? Okay? It's always great to say, oh, we need biomarker data. we need biomedical data, we need bio data, okay? But in some cases, unless you have a nurse who can do that stuff, or besides a simple finger stick, then that's not always feasible. Okay? And that adds a whole nother level of liability and things like that, in addition to staffing and money and blah, 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 blah. So you really got to think through sometimes what's feasible. If we're in the field collecting data, what's feasible? Okay? Yes, pencil paper might be easier. When in this day and age, if we just gave people, like if we had some little cheap tablets that nobody would want to steal, would that be easier to collect the data on? And then if we had a hotspot, then, it could all be online and, it just makes everything easier. So you got to think through what's going to be feasible. The other thing is propriety. Okay, so making sure that the evaluation is conducted ethically and with due regard for the welfare of the participants and the people affected by the results. Okay, you're going to hear me say this over and over this semester. If you wouldn't do it, don't expect community people or your participants to do it either. Okay? Just don't do it. And the other thing you'll hear me say throughout this semester is, if you are not willing to defend what you're doing in a court of law, in this sue-happy society, don't do it. Okay? So if any of y'all ever end up in court and get sued over some stuff that y'all did an evaluation, I'll be like, Your Honor, I told them on the first lecture of class, and I said it several times during the semester. Y'all gonna be like, damn, no, she didn't just get up here. I'll be like, I told them, if you don't want to defend it in the court of law, don't do it. Okay? If you aren't willing to do it, don't expect others to do it. And if you aren't willing to defend it in the court of law, don't do it. Sounds simple enough, doesn't always happen. Okay? And think about you're writing a report. And I know we went through this probably about a year ago with a manuscript from our journal. Okay? They did focus groups, and they had names of participants. But they weren't real names. They were like pseudo names. So, like Joanna's name might be Sue, and Jake's might be John, and so on and so forth. But it still gave the impression that you were identifying people. So we told them they had to take the names out. And they were like, well, we've never had that problem before. I was like, well, look, we're health disparities, research and practice, we don't want to be in the situation of seeming like we're promoting you, talking about people affected by the results. Okay? So think about even too, like when you're presenting results, that's why everything is in aggregate format in terms of your data. Quantitative data, qualitative data, you should not have names. You know, it should be respondent 1, person 2, you know, things like that. And then think through, what is it that you're saying about those people or that organization and things like that. Yes, the organization might not be doing what they're supposed to be doing. Okay, let's just be real. Sometimes, you know, you want to tell the truth. The organization sucks. Okay, the program sucks. Whatever, they just are awful. Okay. You can't always say that, or you shouldn't always say that in a public report, okay? This is why I know, because I get in trouble sometimes, because I do say it. I'm like, you suck. I don't know what more you want me to say, you know? But, so you need to think about, okay, is there something positive that we can say? Or, you know, can we balance positive with negative? You know, suck maybe is kind of a harsh word, maybe not a professional word. So is there something that we can say that, you know, the organization has a lot of work to do to reach their goals and objectives, okay? So you didn't say, no, see the difference now, okay? I didn't say they suck. I didn't say they didn't meet their objectives, just said they have a lot of work to do. You know, so thinking through how you present that information, you know, you don't want to, you know, take, for example, a disenfranchised community and add more to that by saying, oh, you know, they're the worst in everything. Let's try to find something a little more positive, little kind of meaning, you know. Because, I mean, if they were really that bad, at some point they would be gone. They're not gone. So something's working for them. Figure out what that is and try to, you know, come up with your report. Okay? It's about the art of the word and wordsmithing sometimes. And how do we, you know. So, like, for example, I'll tell you all my secrets. Sometimes I get asked to write recommendations for people that I'm like, they don't deserve this, okay? But you don't, like, you're in a situation where you can't say no, okay? Like, for example, I'm the student's advisor. This is like the worst damn student. I've like pulled my hair out trying to get this student to graduate. You know, they rewrite, you know, like major edits on their papers and things like that on their final project. So you don't want to say this student is dumb as rocks, because then it's like it kind of reflects back now on me, because it's like, well, then how did the person get in there, kind of thing. So I learned from one of my mentors that you just talk about the things that they've done. So, oh yes, you know, so and so attended, you know, matriculated through the MPH program at UNLV, and they did a project on this, and I had them in this class. Like, you don't talk about quality. You know, see what I'm saying? I don't say, oh, they were an excellent student. I said, you know, they were a student in my class, and they did this, and they did that, kind of thing. So that you're not the one adding fuel to the fire, kind of thing. And so that's kind of, you know, thinking about the evaluation. You don't want to make things like, I don't want it to come back on me, a student come back to me and say, you're the reason why I didn't get this job. I'd rather say, you know what I mean? I mean, you have to think about this. You don't want to be evaluating an organization and say, oh, they're horrible, they mismanage funds, they da-da-da-da-da-da. That's not your place to say that. That's somebody else's place to say. But you can say, well, you know, they did do this, and they, you know, they had some issues with implementation. You know, don't go to the most egregious issues, but, you know, pick out some minor issues and things like that. Because you're not trying to do what could be perceived as doing more harm to the people in that respect. So you have to, you know, really kind of think through this. You know, again, too, thinking about, you know, like data. you know, like this whole geo mapping is really, you know, people are like into this geospatial stuff and oh, we're gonna document where cases are. But again, like you're dealing with HIV, STIs, things like that that are sensitive. You don't want to then start geo mapping, here's where people live. Because then now you're identifying them. So you just got to really think through what it is that you're doing. So this whole propriety piece, that's why, you know, CITI training is so important. Understanding all of these things becomes very important. The last standard is accuracy. So with accuracy, obviously it should make some sense. You've got to have some technically adequate, valid information about the measures that you're going to be using. We'll talk more. We have like 2 lectures just on measurement issues, okay? Because measurement issues fall into, part of it is in how you ask the questions and you collect the data, and part of it is in what exactly you're asking, okay? So if you ask somebody, are you in love? Okay, well, if I just were to pose that to you all, you might say a number of things. You know, like that might means a number of things to people. Like, yes, I'm in love with my spouse, or I'm in love with my job today, or I'm in love with this class, or, you know what I mean? Love can be a lot of different things. You know, I had this wonderful bottle of water, and I just love water. You know what I mean? I mean, if you just say, are you in love? Well, if you catch me at the right moment, yeah, I'm in love. Catch me at the wrong time, I might not be in love. But it doesn't have anything to do with what it is that we're talking about. I was listening to a faculty candidate presentation today, and he was talking about they were collecting data in China from men, and they were asking them if they drank alcohol. And the men would say no, but then they asked them about drinking beer, and they were like, yeah, but see, beer was considered like soda, you know, or like pop, whatever you want to call it, and not alcohol. You know, it's kind of more of a social kind of thing. I mean, I've seen the same thing in terms of, we did surveys in a community in Florida with Haitian immigrants and asking them, you know, again, you know, the HIV questions, do you have sex? Well, they would say no, but they were married, and you're kind of like, what's going on? You know, I mean, like naturally, you're like, what's going on in your relationship? But for them, you make love to your wife, you have sex with your mistress, okay? So you gotta understand those dynamics. Like, it didn't come out until like we were like kind of going, what's going on kind of thing, you know? And so you gotta understand where people are coming from. If you're gonna get that good data that's gonna tell you what you want to know, you gotta understand how people are thinking and what they're thinking about and how things need to be asked, etc. So we will revisit the framework as we move along through the semester. Here, let me just go back to this slide. So, like, this will be kind of the process that you'll be using in terms of planning and thinking through your evaluation. We'll spend a lot of time talking about this and the different levels of evaluation, but when we talk about, we'll also infuse a lot of our discussion with these issues here. So particularly when you're talking about measurement issues, we'll be talking about these. So how do you get good data that's going to give you the information that you need? Any questions, concerns, comments? I should know this syllabus better, but since I only teach this once a year. Next week, we're gonna start in on process evaluation, okay? So we're gonna be looking at implementation and what are the things that you need to be evaluating, looking at in terms of implementation to make sure that you've got fidelity to the intervention and so that you can document what it is that you're doing. Okay? So, I will see you all next week.